afternoon, everyone. Thank you all for joining us on our presentation today on advancing health equity through community health workers and peer providers, mounting evidence and policy recommendations. This presentation, along with its accompanying report, is the third in a series translating research funded by the Patient-Centered Outcomes Research Institute, or PCORI, into evidence-based policy recommendations. So my name is Denise. I'm a policy analyst here at Families USA. I will be leading the introduction of the presentation, but will be joined by my colleague Emmett, who's also a policy analyst. And our guest speaker for today is Raj Shah, who is the principal investigator of one of the studies that we will be delving deeper into later on. And here is the agenda. So the presentation will run a little like this: a quick overview of patient-centered outcomes research and how it relates to advancing health equity. It will be followed by a brief overview of CHWs and peer providers for those who aren't as familiar with either type of workforce. We will present our translation of 9 patient-centered outcomes research, CHW, and peer provider studies, including a deeper dive into Raj's project with Sunni Indians in rural New Mexico. We will also present equity-focused policy implications and recommendations based on these studies, and then we will leave some time at the end for questions. Before we get started into the main presentation, I want to introduce the Center on Health Equity for System Transformations at Family USA. The center is the only national entity exclusively dedicated to the development and advancement of patient-centered health system transformation policies designed to reduce racial, ethnic, and geographic inequities. The center currently houses 6 projects, including the Health Equity Task Force on Payment and Delivery Transformation, a learning academy to build health equity advocates, as well as the Evidence for Equity initiative. So some background on the Evidence for Equity initiative. This initiative promotes representative and transparent evidence to help decision makers implement health system transformation policies that advance health equity instead of making inequities worse. Health system transformation efforts are more and more rewarding evidence-based care and practices. But to ensure these transformation efforts benefit all, decision makers need evidence that is representative of diverse communities and transparent about specific populations it includes. However, our current evidence base is incomplete and sometimes biased, and that risks that these transformation efforts actually widen inequities. That's why the Center created the Evidence for Equity initiative. We are partnered with the Patient-Centered Outcomes Research Institute to take advantage of emerging research to inform the future direction of policy and health system transformation. So I mentioned that our current evidence base is limited, and it is so in many ways, and we go into depth for why this is and the resulting impact of the limited evidence on communities not included in the research in the first series, in the first report in this series, which you can find on our website. The report is called The Role of Patient-Centered Outcomes Research in Improving Evidence and Advancing Health Equity. But to name a few, historically, clinical and health system research has primarily relied on white young males and has excluded communities of color, women, children, people with multiple chronic conditions, and other populations. The healthcare system has then generalized the results of research and evidence, these incomplete results, to apply to all. The broad generalization of incomplete results threaten to widen inequities. As an example, we know that Black and Puerto Rican children have the worst asthma outcomes, yet the first-line treatment against an asthma attack, albuterol, is less effective for them. Black and Puerto Rican children, of course, are at the intersection of an ethnic minority and children, both communities excluded traditionally from research. Another limitation is the lack of patient-centered outcomes research. research is often driven by biomedical interests without taking into account outcomes that matter to patients. For example, asthma patients may care more about the number of nights of interrupted sleep or missed school or work days than biomedical findings. Patient-centered outcomes research can generate findings that are more relevant to people's needs and daily functioning. Further, when diverse populations have been included, researchers don't always stratify findings in a way that would allow for in-depth analysis, which then helps fund targeted interventions and strategies. So even when race and ethnicity data is available, they are collected, analyzed, and reported in aggregated groups that obscure important differences among subgroups of larger categories like Asian Americans or Latinos. Some groups are often missing altogether from the data, and this includes Pacific Islanders, Native Hawaiians, American Indians, and Alaska Natives. The absence of subgroups in data used in these types of studies means researchers cannot examine important racial and ethnic variations, making the data less relevant and useful. And so it was only by separating the data on Puerto Ricans from those of other Latino populations in the U.S. that it was possible to identify the serious inequities in asthma prevalence among Puerto Ricans, because looking at Latino data overall obscured these critical disparities. And so the limitation of our evidence base is long known and well recognized, and Congress in 2010 created the Patient-Centered Outcomes Research Institute to advance the quality and relevance of evidence to inform healthcare decision-making, which is centered on patients and subgroups. PCOR funds projects that conduct PCOR across a number of research portfolios, including CHWs and asthma. These projects emphasize particular populations, including racial and ethnic minorities, low-income communities, women, older adults, those with multiple chronic conditions, and children, significantly those that have been traditionally excluded from research. And so the portfolio that we will be looking at, the CHW portfolio, includes 70 studies in different stages of completions at an investment of $248 million. So from the portion of completed studies in PCOR CHW portfolio, we selected 9 studies whose CHW and peer provider interventions upheld the community-based CHW model that Emmett will talk about momentarily. The selected studies covered a variety of health issues. Study participants were of diverse ethnic, racial, linguistic, socioeconomic, and geographic backgrounds, and these studies overall produced new evidence that CHWs and peer provider interventions are an effective way to advance health equity, but further demonstrates their versatility in improving outcomes and potentially generating savings.
Thanks, Denise. And so I'm going to give a little overview of community health workers and peer providers. I'm sure many of you are familiar, but just in case, I'll just give a quick overview of these healthcare workers as we selected them in our report. So first, the term community health worker applies to many positions like promotora, community-based doula, community health representative. Even peer provider can be considered a subgroup of community health worker. But their defining characteristic is that they are based in the community and share sociocultural background with the patients that they are serving. And they use this shared cultural experience and background and their understanding of the community to address patients' social determinants of health and connect members of their community with the larger health system. So then peer providers, to some extent, is also sort of an umbrella term that covers positions like peer navigators, peer mentors, health coaches, and most commonly, peer providers work in the behavioral health sector, but they also work in physical health, mental health, and they share with their patients the shared experience of recovering from a particular condition or sharing a specific diagnosis. So one key difference between peer providers and community health workers, and this is something that we go in more in depth on in the paper, is that in Medicaid they're reimbursed as a separate provider type, and for community health workers and and peer providers, the process for provider certification is very different. So in terms of funding these two healthcare workers, there are some distinctions that need to be made. But then there are also, in spite of these differences, a lot in common between these two members of the healthcare workforce. So one key characteristic to highlight, and this is something that was really crucial in selecting which studies and which peer providers and community health workers to focus on in our paper, is that they both have shared experience with their patients. So this might be shared cultural experience. In the case of community health workers, they're coming from the same background or the same community as those who they're serving. Or in the case of a peer provider, it might be a shared experience of being a patient or having the same diagnosis. And this shared experience really helps a community health worker or a peer provider understand the needs of their patients, address barriers that are contributing to negative health outcomes and health disparities. So as Denise mentioned, our new report looks at 9 studies that focus on community health workers and peer provider interventions. They really generate a lot of new evidence to support these health workers' ability to advance health equity. And we want to give you all a chance to go in depth and see one of the PCORI-funded studies that really is generating a lot of valuable new evidence for how, in this case specifically, community health representatives are addressing health disparities in the Native American Zuni community in New Mexico. So I'm going to turn it over to Dr. Raj Shah to give you guys some more information. Shah?
Yeah, thank you. If I have my slides. So, we have been talking about CHWs or CHRs or promoters. Here you see their faces, we train many of these CHRs using Project ECHO in terms of diabetes care, kidney care, and mental health also. So the topic I wanted to talk about, which was funded by PCORI, is to look at how can we enhance the care in kidney disease in Native American communities. And the model I have is, home-based kidney care. One of the things, this model is kind of addressing is that instead of, moving patient and providers, how can we use this, kind of cohort of lay interventionists, basically, who are being used in many ways, but not made as part of clinical care team. So the model I have is basically looking at, how to use them and make them part of clinical care team in delivering care and every aspect of healthcare. So, the next thing which I wanted to kind of talk about is, the population which I have dealt for all my life here, 25 years at University of New Mexico, is looking at Native Americans, American Indians actually in New Mexico. We have 23 different tribes and Navajo Nation. But if you look at the disparity and the numbers comparing to U.S. general population, they are currently 5.2 million as per the 2013 census. And it's a young population. The birth rate is 25.7 versus 15.5 per thousand for general population. The median age is 28 years. They have high rate of everything you can think about in terms of chronic diseases to their life, the way they are poor and having the living conditions in their homes. These numbers really kind of should tell you something, that even though it's a small population in the U.S., there is a big disparity. Tuberculosis, more than 750% compared to U.S. general population. Homicide, suicide. And then look at, safe and adequate water they don't have even, right? So looking at those disparities, initially when we were looking at home-based care, that came out because of we were having data to suggest that in Zuni, which is 150 miles from Albuquerque, small population of 11,000 people, where we saw ESRD, which is end-stage renal disease, 18 times more than U.S. population. And when we compare, that to other American Indians of like some strong heart study, where they looked at Native Americans of Cherokees in Oklahoma to Pimas in Phoenix to Sioux Indians in Dakotas and Alaska Natives, they were still 6 times more than other Native Americans. So it was a really troubling thing. So we went back and looked at the form of kidney disease. So kidney disease is something you have to understand. It's not something where you get your kidney failed right away. And the progression of kidney disease is different in different ethnicity. It's different in different comorbid conditions. So if you're diabetic, you progress faster. If you're hypertensive, you progress faster. And so when we looked at CKD stages in Zuni, we found many of those people were in early form of kidney disease. And so that gave us a chance to think about it, that 50% of kidney disease today is because of diabetes and 25% because of hypertension. So why can't we look at those aspects and see if we can help them controlling their diabetes, controlling their lifestyle, and controlling hypertension? Can that affect that they don't get progress faster? Because Native Americans progress faster in terms of kidney disease. And so home-based care model came because of that, because of the feedback we got from the community, because of some of the barriers with the providers in the community. Indian Health Services is the kind of primary provider for all Native communities across the country. And so we were looking at some of the barriers to healthcare in Native Americans, and what we found that considering their culture, their belief system, their tradition, they are very private people. And so many times, they don't go to doctors. And so for me, then, came about that if they are not coming to us, and the rural area of like Zuni Pueblo is like 3-mile radius, why can't I go there? And so that was the starting point. That was the starting point for thinking about home-based care. Now, looking at this kidney disease, and if you look at those numbers, 35 million Americans in U.S. has some form of kidney disease. In New Mexico, we have more than 70%, and 23% of the Zuni Indians have CKD. Like I said, race, ethnicity, age, obesity, diabetes, hypertension, smoking, these are some of the risk factors. And we spend a lot of money on kidney care. Once the kidneys fail, this is the only chronic disease in America today is paid by us, everybody, by Medicare, basically. And so regardless of your ethnicity, age, or gender, if you fail your kidneys, you'll get support to go on dialysis. And so if you think about it, $23 billion is 5% of the Medicare budget is now being used. I mean, I don't know how many of you have listened to President Trump when he came out about, that there are 2 major companies in America today who controls this market for people who are on dialysis. And so the idea is, why can't we hold them where they are and not have them progress? So let's go to next slide, and I'll give you what we have in our study funded by PCORI. So before we went to PCORI, we went to Medicare, and we said, I have 500 people who are in early stages of chronic kidney disease. And I have this unique idea about going through their homes and see if we can help them control diabetes and hypertension and whatnot. And can you help us fund it? So Medicare was very much interested. This is in 2012. And they came down to Albuquerque and talked to us. And the thing happened after that was that, oh, by the way, you are not helping me to save the money now, which is what Medicare has a model. You tell me if you're saving me money now, then I'll help you. And so I got so frustrated because I knew that if those 500 CKDs, if nothing happens to them, they are eventually going to have ESRD, and then Medicare has to pay for it, right? And so during that time, PCORI came about. They look at my kind of stars, right? I submitted a grant and I got it funded. The idea is very simple, making CHR as part of clinical care team, where we train them to deliver care. So that was one of the innovations. CHR delivered the care. We had patient preferences because in Native American, and even in other ethnicity also, we are not, kind of people who like to listen to anything, right? And so patient preference is one of the innovation we use, which is that, we went through their homes and said, here are different modules for us to talk about. What do you want us to talk about? Do you want us to talk about how to reduce salt in your diet? Or what else? So what does that do to patients? They now think they are part of the care team also. So we found their vested interest in their own care. So that was a beautiful thing to have in any studies. Patient preferences has a major impact. The third innovation was point of care testing. So many of the Native Americans, and many of us even, who would like to have blood drawn and then send it to a lab where we don't get the results right away. The primary care provider will get it and they will send us the results, right? And so there is a lag period then. So point of care can allow you to look at the labs, So you can do A1C right in front of them. In 5 to 7 minutes you get the results. And you can say, oh my God, you're still A1C is 10. You remember we talked about that you need to bring it down to 7. So these are some of the aspects which helped us by doing point of care testing. Then telemedicine. So telemedicine is another approach which helps us because those CHRs who go to people's home, sometimes they have hard time answering questions. And so they then call us on our cell phone and we talk to patient directly. So this is actually really patient-provider kind of interaction through telemedicine. And that actually helps the patient think that they have some private doctor for them, basically. The last thing is text messaging. So we use motivational text messaging as a tool, which were sent every single day 2 to 3 messages, where they don't have to respond though. And PCORI was actually really nice enough to help us fund that aspect of text messaging where we paid each patient to receive the text messaging. Because, to allow on their cell phone with their limited, availability on their phone, we said, okay, we are going to pay you $10 per month to receive text. So these are text messaging which are like very simple. Did you eat together with your family today? How do you feel today? Did you walk out? And so these 5 things you see in the slide, which were part of the intervention. So this was a randomized clinical trial of educational intervention, basically, where we selected 2 groups. One got usual care, meaning we told them that you go to your doctor, which is at IHS, and we actually, the CHRs, helped them if they wanted to go to IHS doctor to go to that clinic. So CHR were not just be part of the home-based care where they visited each household every other week for 1 year. So that was a dose of intervention. And so if you look at the middle column, where we have actually, talked about how many people were randomized in each group. We did initial lifestyle coaching into them. And then we reinforce many of the things which are very easy to reinforce. Now looking at the primary outcome, which is very important to me actually, because I have used this primary outcome, which is patient activation, because we see in clinic every single day, that patients are in different stages. So this is a 13-item survey question which can classify people into different stages. So they can be in stage 1, 2, 3, or 4. And each stage represents their status. So Stage 1 being like you tell them something that, oh, you have a diabetes. They are naysayers on everything. They don't care. For me, they are stupid, actually. Stage 2 is like over the hump, where you tell them something and say, yeah, but I don't have time. Stage 3 are really good people. You tell them something and they say, oh my God, what do I need to do? And so they start doing things. Only thing, they don't sustain it. And stage 4, which is the ultimate thing you want in every patient, which is that you tell them something, they'll start doing it, and they'll sustain it. So how can I move a person who is naive in stage 1 into stage 4? This study which I'm reporting here for today's webinar is because those CHRs who are from the community, who speak their language, who had a vision to have their own people, they went through those homes and talked about all this aspect and motivated those patients and moved patients at least 1.5 points. Actually, you see here 8.7 points. That's the total patient activation score. But in terms of moving stages, each patient moved at least more than 1.5 stage. So if somebody was in stage 1, become 2.5 stage. And so that is unbelievable, because with that, what we found in terms of clinical picture, that they got their BMI reduced by 1.1 kilogram per meter square. One of the markers for inflammation also got reduced. A1C by 0.7% got down. But the important thing in quality of life questionnaire which we administer, the mental score improved in people who got this 12-month intervention. So if you look at the home-based intervention, really improved participants' activation in their own health and healthcare. And it really helped to reduce the risk for CKD in this population. So based on this data, the next slide, where we went back to PCORI and said, well, this is a unique study done in one small community, and we have 23 communities like this here. And we want to make sure that this is kind of transferable to other communities or rural areas. And so we submitted a grant again, and it got funded by PCORI. And now we are conducting the same pilot study into 4 other communities in New Mexico using same model. Only change is in the study design. Because what happened from Zuni study, when we presented the data to the governor, where Joe Selby from PCORI came here and we presented the data, and the governor was like, what is your usual care group? Define to me. And I said, we didn't do anything with them. They were just told to go to their doctors. And the governor is like, how can you do this to my people? You very well knew that they had some kidney disease, and you didn't do anything? And I said, well, that was a technical thing, because that was a randomized clinical trial. And he said, yeah, but you didn't do anything, right? And so when we submitted the second PCORI, we changed the study model, and we said it will be a delayed intervention. So it's kind of like a pragmatic study where everybody is going to get intervention. And so we are in our third year actually of the study. One more year, and I'll come back and tell you about everything what we see in these communities. Thank you for your attention.
Thank you, Raj. And this study really it provides an example of like how one intervention really builds the evidence base, showing how community health workers, and in this case, community health representatives, are really effective for a particular population in improving their health outcomes and addressing some very serious disparities that they're experiencing. And that has some broad implications for policymakers, implications for payers, providers, healthcare stakeholders. And so for the next bit of the webinar, we'll go in depth on some of these broader implications, and we'll be making some more specific recommendations. So the first implication is that community health workers and peer providers improve outcomes, and they also reduce costs. So 4 of the other studies that were included in our report measured the effects of CHWs and peer providers on reducing hospital and emergency department utilization. And in all 4 of those studies that included that measure, community health workers and peer providers were effective in reducing avoidable utilization. And that translates, because these utilizations are so costly, that translates into a savings for the health system. So payers and providers really should incorporate community health workers and peer providers into care teams to improve outcomes, but then to also generate savings. The community health workers and peer providers can be sustainably funded through a number of mechanisms, one of which is Medicaid. Another pathway for sustainable funding is to incorporate community health workers and peer providers into some advanced alternative payment models that sort of share in the savings that's generated by reducing those cost utilizations. So another broader implication is that community health workers and peer providers improve outcomes for a variety of health conditions. So the studies in our report tested interventions to treat a variety of conditions, for instance, chronic kidney disease, other chronic diseases like cardiovascular disease, more acute conditions, spinal cord injury, for instance, as well as severe mental illness. And community health workers and peer providers were shown to be effective in improving outcomes in treating a number of conditions, physical conditions, mental health conditions, as well as chronic conditions. And for chronic conditions, it's really important for patients to, as Raj said, engage with primary care to avoid the worsening of the symptoms, which in turn results in clearly worse health outcomes, but also costly emergency department utilization. So a third broader implication is that community health workers and peer providers address health inequities experienced by diverse communities. So as Denise had mentioned, these studies cover diverse communities and patient populations, many of whom are experiencing disparities. And those interventions that were tested in these studies were proven effective among, for instance, Black patients, Latinx patients, American Indians, patients in rural settings like Appalachia or Native American reservations, patients with limited English proficiency, patients with lower income. And in these cases, the community health workers and the peer providers really sort of act as like trust brokers that connect their communities to the larger healthcare system. And this is especially important in areas like the Zuni Reservation or other rural areas, or even in the inner city where the safety net is shrinking and there's a shortage of providers and a need for someone to connect at-risk patients with the larger health system to get the care that they really need. So another broad implication is that community health workers and peer providers are effective in transitional care. So 2 studies that were included in our report first implemented peer provider interventions in inpatient settings and in the emergency department. And these peer providers, specifically these were peer mentors in one study and health coaches in another study, really help patients to stay engaged with accessing primary care and engaged in their health care after they were transitioned, or after being discharged from the inpatient setting. So this really is evidence that shows that community health workers and peer providers should be implemented in an inpatient setting to help patients transition from that setting into the community and into another setting of care. So then our final larger implication is that research on CHWs and peer providers should be improved. There's always room for improvement to build the existing evidence base. So, I mean, unlike, or much like all other studies, these studies aren't without their limitations. For some of the studies, in some cases, the evidence generated was valuable but still limited. Other studies really served as examples of research done right, especially in terms of focusing on specific populations and identifying and addressing the health inequities that those populations experience. So a couple ways to build a better evidence base. One is for researchers to follow up with patients after an intervention ends to measure the long-term effect of that intervention. It's a measure of the sustainability of the intervention. For instance, it's really important if, for example, if participants or patients are connected with a community health worker for a set amount of time, and eventually those interactions with that community health worker end or become less frequent, it's important to make sure that the improved outcomes that result from that interaction with the community health worker are sustained and continue even after. It just really shows the value of that intervention. The other real key important thing for building a better evidence base, as Denise had mentioned before, is the ability to stratify data or to do subgroup analysis. And for that, it's really important that studies have a large enough sample size where they can stratify their data to ensure that it was effective for the subgroups of participants who are really experiencing the disparities. This is true specifically for studies that include like a really diverse field or a diverse sample of participants. So overall, this research really adds to the existing evidence base. It shows that community health workers and peer providers are really valuable. They're agents of change, really, in advancing health equity. And so they must be a top priority in inclusion into care teams, into healthcare systems, and the payment systems themselves must really fully and sustainably support these interventions and these really valuable agents of change in advancing health equity. So now we have a little bit of time carved out to answer some questions. I know that we do have one in the chat box, and if you have other questions, please feel free to enter them into the chat box and we'll be able to answer them. So the first question is, do community health workers encompass the community health aid program in Alaska? I would say yes, definitely. I think there's a lot of similarities between the community health aid program and some of the community health representative programs that are being implemented and have been implemented for a number of years in the American Indian community. And this is something that it is an example of some sustainable funding that's available for community health worker type programs, something that really must be maintained. I think just because it's been going on for a long time doesn't mean that funding could be cut or something like that. And so the evidence that's generated by these studies really shows that these programs need to be sustained. Any other questions, either for Families USA or for Raj regarding his specific study?
So will a recording of this webinar be available? Yes, we are recording this webinar, and we will send a follow-up email with the recording and the reports in the series. So
go ahead.
One of the questions is, how are CHWs being funded through Medicaid?
So I can try to answer that question. So Medicaid is a state-based program that's jointly funded by the states and by the federal government. So that means different states have very different Medicaid programs, different ways of financing community health workers, and currently only a few states really are are reimbursing community health workers for the services that they're providing. But the process is essentially for direct reimbursement, which is, in my opinion, a little bit more sustainable pathway for funding. Community health workers, well, for sustainable funding through Medicaid reimbursement, community health workers, they oftentimes go through a certification process, and this can be sort of a challenge and a barrier for some members of the community, but it can also ensure that the Medicaid program can directly reimburse. Other forms of Medicaid reimbursement for community health workers happen at the managed care level. So in this sense, a managed care organization would be the person who is directly financing or directly reimbursing the community health worker. That managed care organization, it sort of acts as like a pass-through entity that receives funding from the state's Medicaid program. And in our report, we provide a little bit more detail on some examples of states that are using Medicaid to sustainably fund community health workers.
So can I add to that also?
Yeah, please.
So early in 2012, the governor in New Mexico actually allocated, millions of dollars for CHW program, where, if you are certified as CHW and if you are counseling, let's say, somebody for obesity, you can directly actually get reimbursed from Medicaid. And so that was a very good incentive for those CHWs, to work on their own and not to worry about, getting somewhere employment.
So other questions. Which states are reimbursing for CHW? So yes, as Raj said, New Mexico is one example. Another example is Minnesota, which does have a direct reimbursement pathway for community health workers. And in that case, there's a certification process. In most instances, in order for a state to begin reimbursing community health workers through Medicaid, they have to first submit a state plan amendment, which sort of changes, or maybe not necessarily changes, but codifies community health workers as a specific provider type for reimbursement. And I think one of the best examples for that is Minnesota. Another example, if I'm remembering correctly, is South Dakota as well. And Oregon is another, as one of our participants has noted, as does Indiana. That's right. And I believe in Oregon, and please in the chat box correct me if I'm wrong, but in Oregon, the process, because Oregon has sort of a managed care organization or a form of managed care, the reimbursement might not always happen directly, but it happens through those entities. In Indiana, I'm not quite sure what the process is. Other questions? Report or data on which states are reimbursing for community health workers. So we have a report, and I think we are actually, teaser, in the process of updating that report that outlines community health workers, or which states are reimbursing for community health workers. Has there been an evaluation component with these state programs co-created with a target community? Not that I know of, but I think that is definitely something that's important in terms of really understanding the value of both a community health worker intervention, making that intervention patient-centered, and in ensuring the sustainability and effectiveness of that intervention.
Any other questions?
whether a link to the report is available, and there will be one provided at the end of the webinar.
All right, so we're almost to the end of this, but before we let you all go, we do want to plug in our annual Health Action Conference. It's taking place here in Washington, D.C., January 23rd to the 25th. There's a link there that you can go to catch your early bird registration. It should be a lot of fun. We have advocates from across the country, typically over 500 advocates attend. In the past, we've had Nancy Pelosi speak, Congresswoman Sharice Davids, the First Lady of New York, Shirley McCrae, talk about her mental health initiative as keynote speakers. Additionally, here are the links. There's a link to the Center on Health Equity Action. The second link is the link to the report. And then there is a link to join our HEAT network if you want to keep in touch with any health equity action for transformation news. And we kindly ask that you fill out the survey at the end of the webinar. But thank you all for joining us. We really appreciate all your questions. And another thank you to Raj for participating in the webinar as well. Thank you all.